The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to Iris Telehealth webinar on telehealth policy updates and future predictions with Mei Kwong from CCHP. Thank you all for joining. We're going to wait for a few more participants to join and then we'll get started. All right, we've got a good amount of our participants here now. We're going to go ahead and get started. Thank you all so much again for joining us. Today, we're excited to be partnering with the Center for Connected Health Policy for another webinar on recent telehealth policy updates and predictions for the future. We are thrilled to have Mei Kwong here to share her experiences and what she's seen in the field as we all work to navigate the ever-changing telehealth landscape. Staying up to date on these legislative issues is really important for organizations like ours, as well as community mental health centers, clinics and hospitals, and health centers across the country, as we try and make long-term decisions for telehealth programs. So we're grateful that experts like Mei can come in and help us along the way. Some quick housekeeping before we get started. You should all see a tab where you can submit questions on your window. Please feel free to submit any questions you have throughout the webinar, and Mei will address them at the end of her talk. Also, after this webinar, you'll be receiving a survey on the information covered today. Your answers will help us guide the content we create and share to enable it as helpful as possible for you all in the future. So please remember to fill that out before closing out of the webinar. We will also be donating $20 to the National Alliance for Mental Illness for every attendee who fills out that survey. So thank you so much in advance for providing us valuable insights and for helping us support the National Alliance as they work to improve the lives of millions of Americans. Then before Mei officially kicks off, I want to give you all a quick introduction to Iris Telehealth. We are a telepsychiatry partner specifically for CMHCs, CHCs, FQHCs, as well as hospitals and health systems across the country. We have over 130 active psychiatrists and psychiatric mental health nurse practitioners who can provide care to healthcare organizations across the country. We value high-quality psychiatric care above all else, so we have a very strict vetting process for our clinicians, and we only accept 4% of providers who apply. We are also Joint Commission accredited for behavioral health, and our organization is clinically led, which helps us stay up to date on best practices and ensure that quality care is always at the forefront of our minds. For more information about Iris Telehealth and our partners, you can visit iristelehealth.com. Now, without further ado, I'd like to introduce Mei Kwong with the Center for Connected Health Policy. Take it away, Mei.
Thank you, Allison, and thank you everyone for having me here today. As Allison said, my name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. So before we begin, a couple of quick disclaimers here. So any information that I provide in today's talk should not be considered legal advice. Please know that CCHP always recommends that you consult with legal counsel if you're interested in a formal legal opinion. Excuse me. My other disclaimer is I suffer from seasonal allergies, so my apologies for sneezing or if I have to turn away for a moment to blow my nose. It is that time of year, so apologies for that. Also, if I happen to mention some company or show some type of product, know that neither I nor CCHP has any type of affiliation or relationship with such a company. Next slide, please. And it never fails to have a sneezing attack during the middle of a presentation. So again, apologies for that. A little bit of background on CCHP. We were started in 2009 as a California telehealth policy organization underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant from HRSA. CCHP applied for that. We got it, and we've been serving that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels on specific telehealth projects or research or connected health projects or research. We also act as an administrator for the National Consortium of Telehealth Resource Centers, and we're a convener for a group in California called the California Telehealth Policy Coalition, which is a coalition of over 100 statewide groups that are interested in advancing telehealth policy in the state. Next slide, please. So I've been asked to give an overview of what's happened since that initial rush of telehealth policy changes that happened at the beginning of the pandemic, really from that period in March to about the beginning of May of 2020. Now, this is a landscape overview of like those changes, and this is your 100,000 foot level overview of what has happened. So very short on details, but really focusing in on sort of the areas that those telehealth policies have touched upon. And you see both on the federal and the state level, there's a lot of commonalities. And that's usually because there's like certain commonalities in certain areas in which there is like a lot of telehealth specific policies that exist. And I'm just gonna have to pause one moment. And apologies for that. I am not in this talk going to go over those early changes, those changes at the beginning of the pandemic. I'm going to go over what has happened over the last few months, what changes have been made. If you are interested in hearing more about those early changes, those changes that took place in early 2020 from that March to early May period, there is an appendix for the slide decks. And I understand that all attendees will be receiving a copy of the slide deck, so you can go and refer to those after it, but we won't really be talking about any of those during this talk. So this overview is just providing you with like what has happened during the time. And also, as a lot of you can probably tell, a lot of it was around reimbursement. There were other things that were changed or temporarily suspended, or temporary relaxations and expansions were made, such as on prescribing or on licensing or on HIPAA. But for the most part, a lot of the temporary changes that were made at the beginning of COVID where telehealth was concerned really was around what's covered and what's going to be paid for. Next slide. So first off, we'll tackle federal policies. Next slide. And we're going to hit Medicare first. So on the federal level, where you're talking about telehealth specific policies, it is really about Medicare. There are obviously other policy issues that impact telehealth, such as prescribing, the Ryan-Haight Act, privacy, HIPAA, that type of thing. But a bulk of the established, very telehealth specific policy is around Medicare and how Medicare treats telehealth. And to understand Medicare policy, you also understand that Medicare has two, what I sometimes refer to as buckets of policy. They have their telehealth policy and they have their communications technology-based services. Now, what are the differences? So your telehealth policy is your very specific telehealth policy under Medicare, and it's embedded in federal statute. It is where, you know, the limitations that a lot of people are familiar with that are pre-COVID-19 come into play, such as, telehealth services can only take place in a rural area, and there's a very specific definition of what that means. It can only be given by, you know, these types of providers. This is a limited list of services. That is Medicare's telehealth policy, and as I said, a lot of that is embedded in federal statute. So Medicare doesn't have administratively much control in like what they do with that policy. It is, their limitations are in federal law. They really need Congress to change that before they can act. But that is what they regard as their telehealth policy. Now, they also have a different bucket or set of policies called communication technology-based services. And these services do utilize telehealth technologies to deliver those services, but they're not called telehealth. They're called communications technology-based services, or CTBS. And because they're not regarded as telehealth in Medicare's eyes, they don't have the same level of limitation as telehealth does. They're not held to the standard of those restrictions that are in federal law. So Medicare, CMS, can really craft their own policies around CTBS. Now, they both utilize telehealth technologies. Why are they regarded differently? And in Medicare's explanation is, well, when you're talking about telehealth, you're doing really a replacement for in-person services. So, you do an office visit with your physician. So that you can do via telehealth. It's a one-to-one replacement. Whereas CTBS services, there's services that you can provide via technology that you really wouldn't provide in person. So let's say remote patient monitoring. You have a patient who has hypertension, they're taking blood pressure readings maybe several times a day, and they're transmitting that information to their healthcare provider. Well, you typically wouldn't see that in person. You would not see somebody going into like a clinic or something, getting their blood pressure readings a couple of times a day, doing that for 7 days a week. So what CMS has explained is that because technology now has gotten us to this place of providing services that we didn't imagine before, but we can do now and do safely and effectively, it's this other category. So it's CTBS, communication-based, technology-based services, and we can create the rules on how that's operating. Now, the reason I'm spending so much time on this is because it's gotten a little fuzzy, I think, for some people, and mixed, as in they've used the overarching umbrella of telehealth to cover these things. And for some jurisdictions, they do say telehealth covers all of these, including those typical CTBS services. But Medicare has very distinct policies for them. So their approach is very different, and the rules and requirements around them are very different. It's gotten a little muddled over the years, or not over the over the past year during the pandemic, in that they've been kind of smooshed together, and some may regard CTBS services, they think they're providing telehealth, and sometimes they'll wonder, well, why am I getting such a low reimbursement for this service? I provided it via telehealth and it's supposed to pay the same thing as it would have had I done it in person. And then you figure out what they're coding it. They're coding it as a CTBS service, so that's why. So just wanted to make that distinction so people understand that, because there are policies coming out that impact both streams. Next slide. So the federal policy changes that took place around COVID, I said a lot of them had to do with reimbursement and what Medicare was doing. So when you look at reimbursement policy, there are 4 essentially basic elements in how reimbursement policy is typically structured. It's around the service, location, the modality, and the provider. So you might have a policy, let's say a Medicaid policy, that says, this Medicaid program will pay for mental health services when the patient's located in a clinic setting, when the service is being delivered via live video, and the provider who's providing that service is a psychiatrist, we will pay for that. So those are sort of your basic elements of how reimbursement policy is set up, both on the state and federal level. And again, why you had those common areas in which there were policy waivers. It was usually around one of these elements here. And what the feds did, just very briefly, is they impacted practically everything on here. They expanded the list of services that were available. They expanded the location to include the home. They expanded the list of providers who provide services, and the modality, they expanded it one way in that they allowed audio only to be provided. And as most of you know, audio only was allowed because not everybody had access to live video, so audio may have been the only way they could provide those services. Now, these so far have been temporary changes for the most part, but some things have been made permanent, so we'll get to that next. Next slide, please. So this may be a little bit hard to read. I understand, again, you will get copies of the slides, so don't worry about it. But this is just an overview of like, what was pre-COVID situation, what were some of the temporary changes and permanent changes made so far. Not really a lot on the permanent changes, and we'll get into more detail about that, but just wanted to give you like an overview here. Next slide. So there's two ways of making permanent changes. You can go an administrative route, and that's CMS doing regulations, or you can go a legislative route, and that's your bill being passed through Congress and the president signing it. And again, next slide, we'll go more detail on what has happened in both channels. So your administrative changes is basically CMS putting forward changes. And as I said earlier, CMS does not have a lot of leeway in like what they can make permanent. They need Congress really to act. So, but one area that CMS does have administrative ability to like change in one of those elements of reimbursement policy is the service element. So CMS can propose what services to put on that permanent telehealth list. And that's what they did. And they typically do that through the physician fee schedule. For those who are not familiar, physician fee schedule, it is a set of proposed changes that CMS makes every year to impact the Medicare program the following year. So for example, last year they came out with their proposals in early August of 2020 for changes that would be made to the 2021 Medicare program. They put their proposal out in the summer. They have to have a period where there's a comment period by the public, and then they do their final proposal towards the end of the year saying like, okay, these are the changes that are going to happen for the following year, and in our case in 2021. So they did make some proposals on what to make permanent. And again, the only area they really had any leeway was in, as for telehealth is concerned, was in like what services are covered. And if, for those of you who may remember, at the beginning of the pandemic, CMS added about 140 additional service codes on the temporary list to be allowed if telehealth was used to provide the service. So they really just added on the permanent list from that a list of 140 about, was it 8 or 9 different service codes. And those are the ones that are now on the permanent list. So if the public health emergency was over, then these codes would still stick around and be eligible to be provided via telehealth and get reimbursed by Medicare. Next slide. Now, what they also did though, so how CMS decides what gets on the permanent list, what codes get on permanent list, they have two ways of doing that. And basically it's two tests. So you can either have a code get on the permanent list by passing a category 1 test, which is the code is very similar to what's already being reimbursed on like the permanent list. So it's similar to like another code on that reimbursement list. And if they judge that it is very similar, what they do, they say that yes, it's fine. It passes that category 1 test and gets on a permanent list. There's a category 2 test that basically says, well, you can propose a code to be added to the list, and if there's basically enough evidence to show that it's effective, a way of providing services via telehealth, then it can like pass and get on that on the permanent list as well. It passes the category 2 test. Category 2 test, very hard to like pass. Part of the reason is because there hasn't been really like explicit detail. I'm like, well, what's sufficient evidence? Do you need like a study where 1,000 people were involved, or do you need to like be in 16 published peer-reviewed journal articles? It's not quite clear. So usually, typically, things usually just get passed on a category 1 basis. Well, this past physician fee schedule, CMS said we're going to create, for now, a category 3. So our category 3 is for those other temporary codes on the COVID temporary list that we think would be good to have around, but we haven't had enough time to gather enough evidence for it to see if it's a feasible way of providing via telehealth. So we're going to put them in category 3. So these codes in category 3, what that means is they're in this temporary category that if the public health emergency ends, these codes can stick around and still be eligible to be provided via telehealth and get reimbursed for until the end of the year of that public health emergency is declared over. So let's say the public health emergency is declared over June 1st, these codes will stick around at least through December 31st of that same year. And they did that to say, like, that additional time will allow us to gather additional evidence to see if it passes on, you know, either a category 1 or category 2 basis. Most likely they're thinking category 2, because if it passed on category 1, it probably would have already been on the list. But there's insufficient evidence to like pass the test to like get onto the permanent list. So many more codes put onto that, you know, category 3 bucket. So that's a more extensive thing, but it's still, keep in mind, this would still be temporary, because they would only still be viable until the end of the year the public health emergency is declared over, unless they basically show that there's enough evidence where they can be moved on to the permanent list. Next slide. So this is where CMS then like shifted their gaze to like the communications technology based services and what they were doing around that. And so there was a lot of sort of clarifying on like, you know, what some of the policies are around this. And keep in mind, they're again, for CTBS, they're not really held to like those telehealth limitations that are in federal law. So they have a lot more leeway in how they created the policies, which includes adding additional providers who can use these codes or provide services via this technology if they fall underneath CTBS. So that's basically what they did. They offered a lot of clarifications. They expanded it to like other providers who could use these codes and bill for them. But this also shows you the difference of like, you know, how they can like, the difference in like their control over the policies around like these two different buckets of technology delivering care. They have telehealth, which is very restricted because of federal law, and then this area where they have a little bit more leeway in like what they can do with it. Next slide. Other things that they've done. Now, I said a lot of the policies around reimbursement, and it is and it has been, but there also were some policy changes made during the pandemic that didn't necessarily have to do with reimbursement, but maybe it had to do with other things such as like supervising additional staff, if you can use telehealth to do that, frequency limitations on how often you can use telehealth. So there have been some permanent changes to that. One example is like with skilled nursing facilities. Before the pandemic, if you were a resident in skilled nursing facilities, you can only receive one telehealth visit every 30 days. There was that frequency limitation. During the pandemic, they said frequency limitation doesn't apply now. You can receive however many visits during the month, during your stay at the skilled nursing facility. For a permanent policy change, they did decrease or increase, I guess you would say. They shortened that window on how often you can get the telehealth visit for the skilled nursing facility. They said once every 14 days as opposed to 30 days. So there were these other changes that were made that maybe didn't necessarily also impact reimbursement, but like how you can use telehealth that CMS was incorporating into their permanent policies. Next slide. So that was your administrative route and how you can make changes. Your next route is basically your legislative route. And so what was done to make some of these temporary waiver changes permanent? And really not a lot. So there was one other sort of significant federal legislation that was passed. I'm not going to talk about the reconciliation bill, and that technically has not passed yet. So I think the House is voting on it today, and then they're going to send it to the president. So we'll just leave that aside for now. But the last sort of major one was back in December, the Consolidated Appropriations Act. It was passed in December 2020. Some of you, it may have like slipped underneath your radar because it was around the holidays. Also, there was not a whole lot of telehealth in there. There were some telehealth things, but really nothing about like the temporary stuff that we saw again at the beginning of COVID. There were some telehealth changes in there, but nothing really specific to those temporary changes that we have seen happen. So what were the telehealth provisions? They basically added another eligible originating site to like basically permanent telehealth policies, and that is critical access hospitals or other rural facilities with under 50 beds. So they're going to call this grouping rural emergency hospitals. So that becomes like a new eligible originating site. And then they also said a permanent telehealth policy for Medicare would be mental health services can be provided via telehealth without the geographic restrictions or the site limitations, so they can take place in the home. But they added a caveat. They said, however, in the period 6 months prior to receiving those telehealth services, the patient must have had an in-person visit with a telehealth provider. That suddenly really restricts like where you can get telehealth from, because you may have providers who are great distances from their patients. That's one of the beauties of telehealth, is that distance doesn't matter. But now requiring them to have that in-person visit will basically very limit the options then of the patient. I do want to say though, that only applies if you're trying to get out of the geographic and location limitations. Like if you're trying to like be able to access this from work in an urban area or something like that. So they're not going to require that a patient has that in-person visit if they are in like one of the eligible originating sites that typically happens in if they're in a rural area. So basically your kind of classic model of the patient going in to say like a doctor's office or a federally qualified health center, and then they're hooking them up with like a telepsychiatrist or something, that doesn't, and they're in a rural area, that doesn't mean they need to have an in-person visit. It's only when you're trying to get the visit outside of the geographical restriction and like your typical originating site list of things. So that was sort of, it was nice that they were including the expansion for telehealth services for mental and behavioral health, but having that in-person requirement really starts to limit your options. Then there were other things in the Consolidated Appropriation Act, which is additional funding, such as another $250 million for the FCC COVID telehealth program, and then more funding for broadband, which was good to see, but it's I'm not quite sure how far those funds will go when you consider we're talking about an entire nation. But it was nice to see like a step in that direction. So next slide, please. So the PrEP Act declaration, this also happened towards the end of last year, like I believe it was around November, around Thanksgiving. For those who are not familiar, the PrEP Act, basically when it was first introduced, is a way to provide malpractice coverage for those who are treating patients with COVID. It's basically, if they are doing certain things, like a specific set of services and a specific type of provider, and it's essentially like you're treating somebody with COVID, you have this malpractice coverage, so you can treat those patients without too much concern about being sued. What they have been doing with the PrEP Act is they've made amendments throughout the pandemic, such as like adding things. And what they added, they did two things back in November. They added telehealth providers to those lists of like covered providers. But they're very specific on like what a telehealth provider is. So basically they're saying like, somebody who is licensed within their state, who can provide services via telehealth, they are eligible as a covered provider, but then they have to be providing certain services to basically come underneath this PrEP Act protection. So their services are called covered countermeasures, and they're very specific as what they are. The list is there that it is a qualified pandemic or epidemic product, it's security countermeasure, drug, biologic, etc. So it's very narrow. But the other thing that they added along with like the malpractice coverage was to say that if you are a telehealth provider doing this and it's a covered countermeasure, then you will not be subject to the licensing laws if the patient you're treating is in a different state from where you're licensed. So it was a licensure exemption that they were offering also to telehealth providers. Very narrow. Again, it's you have to fit in their definition of what a telehealth provider is. So while I don't think there's anything that exists there, but let's say you're in a state where it says you're a type of provider who's not allowed to use telehealth, then you wouldn't qualify as an eligible provider. And it also has to be a specific type of service. So let's say you were a provider, a dermatologist who is treating somebody across state lines, you're not licensed in that patient state, and you're treating them for like a skin rash that they got to a food allergy. Would not qualify under this. You would still need to be, depending on the state, and a lot of states do waive licensure requirements, but let's just say for this example, you would still need to, the licensure laws in that state would still apply to you. But if you're treating them for COVID and then you were using something that fell underneath one of these covered countermeasures, you would like qualify for the licensure exemption. Again, very narrow, but it was the first sort of like really federal sort of licensure policy where they directly address the licensure policy in some way. as opposed to like, what happened early in the pandemic when Medicare said, well, at least in the Medicare program, we'll loosen some of the licensure restrictions. This was a statutory thing that they did too. So next slide. What can we see looking forward? So we know at least that the PHE is extended through the end of the year. There was a letter that was circulated early in the year from HHS to all the state governors saying like, we're going to extend it to the end of like 2021, but we will give you about 60 days notice. So there's like, that eases the fear of everybody having like earlier of like the cliff effect of like suddenly just the public health emergency expiring and people not knowing what's happening and you just abruptly end all these temporary policies. What we may see from the Biden administration is we do know that at least his nominee for HHS, Xavier Becerra, has at least indicated his support for telehealth. What that all means, we're still not quite certain. There hasn't been any like specific policies that have come out. I have a slightly more conservative viewpoint of what's going to happen with telehealth policy. I think there's been a bit of pumping of the brakes, not possibly also from the Biden administration. Biden administration is still not entirely clear where their position is, but also from Congress as well. There was an Energy and Commerce hearing last week. There were a lot of questions brought up, a lot of concerns, such as like, do we keep audio only around? Concerns about fraud, those types of things of like, what should we keep around? We have concerns about quality, etc. And I also think that there may be a bit of a, as I said, pumping of brakes on telehealth policy and what we do with it, because I thought if anything was going to be made permanent, they would have done it in the Consolidated Appropriations Act back in December, and they didn't. So that was a flag of like, are things slowing down here for telehealth? And also I said I really wouldn't go into it, but with the Reconciliation Act, again, not seeing temporary policies slipped in there in some way. So, and actually really some telehealth pilot funding and stuff, but not really a lot of extensive things for telehealth in that Reconciliation Act that I saw. There were a couple of things, but not really like broad things. So I think there might be, at least on the federal level, a little bit of a step back to do assessment of like really where do we stand, and perhaps a little bit more conservative approach towards telehealth in the coming months. Next slide. States and what are we seeing there? Next slide. So before the pandemic, you had Medicaid programs, at least on their fee-for-service side, every Medicaid program reimbursing for some telehealth that's done via live video. Usually, I'll be honest with you, it's about mental and behavioral health was the favorite. Store-for remote patient monitoring, a little less popular, and that's important to note because if a state Medicaid program allowed the home to be an eligible originating site, it was usually because they were doing some sort of reimbursement for remote patient monitoring. So if you only had 21 states, that means you had like less than half the states allowing the home to be an eligible originating site. Very important when you're talking about a pandemic when people were sheltering in place at home. So that's why you saw a lot of places, not only on the federal level, but on the state level, saying like, we're allowing the home to be an eligible originating site. Because a lot of them didn't have that allowance before the pandemic. Next slide. States also have commercial payer laws, or private payer laws, as like some people refer to them, and they range in everything from a state that says health plan you can cover telehealth delivered services if you want to, all the way to a state that says health plan you shall cover telehealth services the same way if you would have had it been delivered in person, and by the way, you will pay the same amount for that service. And then everybody else kind of falls in between. This kind of dictated what states were able to tell commercial payers what to do during the pandemic, as in those early days of as far as like where telehealth was concerned. To credit of a lot of payers, they just automatically also did do it themselves without direction from the state, but it was helpful possibly in states that had a more widespread telehealth policy already on the books dealing with plans than maybe states who didn't. Next slide, please. Trends that we're seeing as far as legislation. So I think on the federal level, we talked about it, is that I think there might be a bit of pumping of brakes, even though like bills that were introduced last year that didn't go anywhere have been reintroduced again, like the TREAT Act that deals with licensing, that's been reintroduced as well. State level, what we're seeing is payment parity for private payers. These are like pieces of legislation and the trends that we're seeing that have been introduced. Telephone and Medicaid. So we are seeing some audio only being made permanent on the state level. Usually though, it's very limited. It's usually for like mental behavioral health or for other sort of set services. It's not like a widespread, you can kind of provide a multitude of things via audio only. It's like very sort of like narrowly focused on what's allowed. Licensing about state providers, that's been a sort of more popular topic with legislation that's being introduced on the state level, was flagged as a significant issue during the pandemic, and the requirements for regulatory boards to create like regulations around telehealth. So before the pandemic, if licensing boards or regulatory boards had anything around telehealth policies, they were usually kind of vague in that they may have said like, you will abide by the same standard as you would have had the service been provided in person. You would follow the same rules like around privacy and security and HIPAA that you would have if you'd done the services in person. Now there's been a bit call of like maybe providing a little bit more detail on like what is expected from licensees or when they utilize telehealth to provide services. Next slide. And that is about it. So we've got some time, I think, for some questions if we wanted to open it up. Allison, I'll turn it back to you on how you want to handle that.
Yeah, absolutely. We've got a few questions that came up during your wonderful talk. Thank you so much again for all the great information. One of the first questions that we got here was, can we get a copy of the slides? Yes, everyone will be receiving a copy of all the slides and the recording of this webinar in a follow-up email from me later this week. So don't worry about that if you weren't able to read through everything and absorb all that information. You can see that Mei also had some links throughout to be able to click those and go to that information when you receive those slides as well, to keep getting great resources around this topic. Now, our next question for you, Mei, is, do you anticipate a significant increase in telehealth grant funding opportunities in the coming months? Do you have any answers for that?
Yeah, actually, so that is part of the Reconciliation Act. There was some additional funding in there for certain grants. There was some with like rural services, some around SUD and opioids. So there's that on the federal level as well. There continues to be interest, I think, with some foundations around telehealth and how it could be used to like help certain populations. The thing is that it's probably going to be very focused on like certain areas. I know folks here are mainly in mental and behavioral health, so that is always a popular area. And also, if you're looking at or are providers who treat substance use disorder, again, I think there's also going to be more attention paid to that. And I mentioned that for the states that were making or allowing more expansive policies, permanent policies for audio only, and that was on mental behavioral health. A lot of those were also connected to treatment of substance use disorder, opioid use disorder patients as well. So again, that's going to be a pretty popular area that people want to explore in using telehealth a bit more to treat people with those conditions.
Absolutely. And you touched a little bit on it on this next question in your answer, but is there any other behavioral health specific information or where the behavioral health landscape stands right now as far as telehealth policy? Any other insights you could offer around that you haven't covered so far in your talk?
I talked about OUD and SUD. One area that CCHP is particularly interested in exploring a little bit further, and again, there was a little bit of this in the Reconciliation Act, is using telehealth to treat victims of domestic violence and sexual assault, which for those of you who may have been tracking this, incidents of domestic violence has increased during the pandemic as well. But it's been a little bit unexplored, I think, with telehealth. A couple of years ago, it had like a lot of interest for a while, but over the years, the last couple of years, it's not really risen to a lot of prominence. But I think I think there's like great application there, but you do need to, I think, be a little bit more careful in like how you provide those services, just because, especially if you're like, again, during the pandemic, because the abuser might be there if you're like doing services from the home. So you got to be a little bit more thoughtful about that. But I think that's also an area where I think there's like a shortage and it should be explored more. And then given what was in the Reconciliation Act, there may be a little bit of interest in that from the policymakers' viewpoint too.
All right, absolutely. Thank you. That was fantastic. And one last question that we have here, you talked a little bit about licensing for out-of-state providers. Do you have any sort of idea or guidance on around what states are the most restrictive around licensing for out-of-state providers right now as far as telehealth?
So I'm in California, so I would put California on that restrictive list. Yeah, because there have been a couple attempts over the last couple of years of like, trying to join. For those who don't know, one of the ways to address sort of the licensure issue is to have compacts. So licensure compacts where you join a compact, and depending on how the compact is set up, it's supposed to make it easier then to like practice in other states if they're a compact member. So yeah, over the years there have been attempts to like try to get California to join a compact, and it has not happened. We were also one of the states that had one of the most limiting kind of licensure relaxations during the pandemic. It was a well, if you can get a facility to apply for you through the Emergency Services Administration through this application, then you don't need to get a license, but you have to go through that facility route. Unlike other states, we're just saying like if you're in good standing in other states and all that, and you just check in with the medical board, you're fine to practice without a license. So California is definitely one of the more restrictive ones. There have been a couple of states, and I'm sorry if I'm getting this wrong. I want to say it's one of those Southwest states. So it's either Arizona or New Mexico, but one of those where they are looking at relaxing or have relaxed some of their licensing laws as well to allow, greater ease of providers to provide services within the state. So don't quote me on exactly which state on it. If people are really interested, I can get that information to Allison if she can like send that out. But California, definitely one of the more conservative states in that area.
Mm-hmm. Absolutely. All right. Well, thank you. Thank you so much for answering those questions. That's the last question that we have here. I want to thank you so much again for taking the time to speak with us today and sharing all this fantastic information. Again, for everyone who's with us still, we will be sending out all of these slides and the recording of this webinar so you can hear all of Mei's fantastic insights again. And you can check out our contact information on this side if you need to reach out to CCHP or Iris Telehealth in the future. Don't forget to fill out our brief post-webinar survey. Again, this is just a survey to help us get feedback around, what kind of content would be helpful for you all. More content like this fantastic breakdown Mei just provided us for other kinds of content that would be useful for you all as you continue to expand your telehealth strategies in the coming year. And it should take less than a minute to complete. And again, later this week, you'll be receiving an email from me with all the fantastic information. And just want to thank Mei one last time and hope all of you all who had a chance to join us today have a wonderful rest of your day. Feel free to reach out to us if you have any other questions, and you'll be hearing from me again soon.
Thank you. Apologies again for the sneezing.
Bye, everyone.